So, good morning, good evening, and good night from everyone from across the globe that's joining us for this edition of the EIOC Journal Club. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the very sunny, very bright, very hot, and very safe United Arab Emirates. And I'm joined today by some spectacular regional as well as international faculty that's going to be walking us through and discussing with us the issues surrounding the use of immunotherapy in the realm of patients with non-small cell lung cancer. So I'm going to allow our faculty to introduce themselves. If you can bring the next slide. Yes. So Christian Rolfo, please introduce yourself.
Yeah, hello everyone. My name is Christian Rolfo. I'm a thoracic oncologist. I'm the division director of medical oncology at the Ohio State University and associate director for early phase clinical trials here at the Cancer Center. Nice to meet you.
Thank you. Dalia.
Dalia ElShorbagy, consultant medical oncology, SSMC, Abu Dhabi, UAE.
Sonia.
Hi, good evening, everyone. Sonia Otsmane. I'm medical oncologist, hematologist, consultant, and Rockville Medical City. And thank you for keeping us with this nice meeting.
Zamzam.
Good evening, everyone. This is Zamzam Al-Hashami, medical oncologist at SQCCRC, Oman.
So thank you all for joining us. Let's put up the slide for the agenda, please. So we're going to first allow Christian to give us some real-world immunotherapy cases in patients with advanced non-small cell lung cancer. And then we're going to deep dive a little bit into some of the discussion points that we have for patients with immunotherapy in that first line or even, heavily pretreated group of patients. So Christian, please take it away.
Thank you very much. Give me 1 second. I will try to share my slides. I can stop sharing. Can you see my slides? Can you see my slides?
Yes.
Yes,
Okay.
it's very clear.
So thank you so much for the opportunity to discuss today about, I put some case to represent specifically in immunotherapy, and I want to focus in a patient that is less than 50% non-small cell lung cancer, PD-L1 non-small cell lung cancer advanced disease. So that's are my disclosures. So this is a patient with 65 years old, a woman with former smoker, 40 packets per year, ECOG-1 when was diagnosed. This is a case from one of our colleagues. ECOG-1, as I say, pleural biopsy was confirmed an adenocarcinoma with infiltration and having a CK7 positive, TTF1 positive, and NAPSIN1 positive. The NGS tissue show an KRAS G12V and STK11 mutation, and the PD-L1 status was 40%. So if we are looking at the treatment options that we have for patients with non-oncogenic drivers, there are several opportunities, and they are, if we are focused specifically in the patients that have PD-L1 expression, in the case like this case that is from 1 to 49%, we have different opportunities like pembrolizumab, carboplatin, pemetrexed, or cemiplimab, carboplatin, pemetrexed. And we are offering also other combinations. Can we offer other combinations that might be offered in selected circumstances, like you have here that are different schedules that are conditional, but these are the strong one opportunities. We saw in this, if you are looking, for example, in PD-L1 in general, in some of the trials, all the majority of the trials, we say all the trials have a benefit, important benefit, market benefit in this population. So as the first line options for patients, we are looking at specifically in this population some factors that are influencing this first line treatment decision. Obviously, if we are looking at the data, we want to know about the data on efficacy and safety. That's the most important. We are looking for characteristics of the patients like age, performance status, smoking status. We know that there are favors for monotherapy in patients that have more than 50% and current smokers. Comorbidities, patients that have some issues for accepting immunotherapy that are excluded, contraindications, that are the most important, and the patient preference for the schedules that we are using. If you are looking at disease characteristics, we know that several of the trials were including some sub-analysis in specific populations like liver metastasis, brain metastasis, and also we are taking in consideration the tumoral burden, the disease burden volume, and the symptoms that the patient have. And obviously, if we are looking specifically at the characteristic beyond the PD-L1 expression, and I would say TMB could be something that we can leave it outside because we know that all different trials are very difficult to interpret what is the real role of TMB. But we have other biomarkers like the co-mutations, and these patients have an STK11 and a KRAS mutation, and obviously the presence or not of oncogenic drivers. If we are looking at the pool analysis, if we are looking at the data of immunotherapy in patients with less than 50% of PD-L1 expression, we saw that the immunotherapy versus the chemoimmunotherapy are obviously in favor for the combination, and that is not a notice. This is not new. We know that, and we are treating the patients in combination. And if we are looking specifically for, like in this case, KRAS mutation and efficacy for immunocheckpoint inhibitors, we know that the prospective data, the pool analysis that are from 12 randomized trials that are including 1,430 patients, the combination of chemoimmuno, the KRAS mutations have a similar overall response rate and a similar overall survival when we compare KRAS wild type versus KRAS mutated. The things are in favor for the obviously for combinations in this case. And if you are looking specifically in STK11 and other mutations like KA1 or KRAS, the idea to have this as a limited effectiveness for immunotherapy alone is more frequent. So we need to go for these patients in combination treatment. Actually, some hospitals or some institutions are doing some specific schedules or schemes for patients who have different alterations in non-oncogenic drivers, but in mutations like these ones. So if we back to our case, the patient started the first line treatment with carboplatin, pemetrexed, pembrolizumab. And after 12 weeks, you see they are in the CT scans. You have a partial response in the lung and also in the liver metastasis. If we are looking at the data that we have for the Keynote 189 and the phase 3 trial that was used in this case, for example, we saw that the trial was randomized in 2-to-1, pembrolizumab, pemetrexed, and carboplatin or cisplatin versus the chemotherapy, combination of chemotherapy with carboplatin alone, and stratified by PD-L1 expression. The patient will continue with pembro and pemetrexed in maintenance up to 31 cycles, and then at progression there were opportunities also to do rechallenge. So the overall survival of this trial is we have data already for more than 5 years, but these are the data presented in 2022, and 5-year overall survival is consistently maintaining the benefit, 19% versus 11.3%. So if we're looking specifically in median time is 22 months compared with 10 months, 10.6 months, and a hazard ratio of 0.60. And if we are looking specifically in the population that this patient is following, that is the PD-L1 1 to 49%, we have a 0.65%, 0.65 hazard ratio. And if you see also, even patients who PD-L1 less than 1%, the benefit is also clear in this population. The progression-free survival is 0.57, and specifically in this subset of population in 1 to 49% of PD-L1 expression. And the 5 years progression-free survival in the entire population, in the ITT population, is 7.5% versus 0.66%. So it's really a net benefit. And you see the curves are separating very nicely from the beginning. So this patient complete after 24 months, the 2 years of pembrolizumab in maintenance without going in progression. But after 15 months of the treatment, the patient have a recurrence in the brain and in the lung. And that was 18 millimeters temporal met, started dexamethasone and SRS. And the pleural implants have also, as a companion, the pleural effusion. So what are the data that we have in these patients who completed already 35 cycles of pembrolizumab? The overall survival rate after completed the 35 cycles is 71.9% in the studies. And the patients that are alive without progression or subsequent therapy is around 23% of these patients. So if you see the swimmer plot analysis that you have here, some of these patients are continuing and some of them are progressing very quickly. So we need to focus in some of the patients that are longer responders. There are not studies that allow us to stop having a biomarker to stop or to continue the immunotherapy in some patients, and we know that this is a difficult situation, a difficult discussion that we have with the patients. We are running right now a trial that is in Germany and here in the United States that is called the Penelope trial, and that will be a trial that will answer these questions, including PET scan, and we will do in the United States the part of the liquid biopsy of that. So trying to get a biomarker to have a better conversation with our patients when we want to continue or not after the 2 years. What is true that the re-challenge following pembro discontinuations in the Keynote trials was if we are looking at the Keynote 010, 1 year of treatment, the overall response rate was 43%. It's a very small number, 14 patients, but 70% of these patients have clinical benefit. And in the Keynote 024, 1 year off of treatment, the overall response rate was 33%, numbers small, 12 patients, but 83% of clinical benefit. In this case, there was a pembro re-challenge with the patient, so we back to pembro, and the patient is currently maintaining the response for 11 months. So this is the case, and that's my team, but I'm happy to open for discussions and see what our colleagues are thinking about this case and other topics that we will discuss. Thank you very much.
Thank you. Thank you for actually walking us through that entire case, which is very, very practically driven. Does anyone here have any questions? Because I have plenty of questions to ask. My first question, as people start to think about the questions that we can pose to you, is if a patient has a PD-L1 score of, say, 90% at presentation, your patient had a PD-L1 of 40%, but say suppose the patient had a PD-L1 of 90%, fit, young man, smoker, but has a lot of burden of disease, no brain metastases. Would you prefer single agent immunotherapy or combination with chemotherapy, or do you need more information about the molecular markers of this patient? The patient doesn't have EGFR or ROS or ALK-BRAF or any of those, but do you want to know information on the KEAP STK11? And do you routinely do that in your clinic?
Yeah, so that's a very good point. So depends of different factors, but generally I personally go for monotherapy, but I know that is a point of discussion that we have with some colleagues that they prefer to go for combinations. But I think in the one of the first slides I show some of the characteristics that are influencing us to go for the selection of the drugs, no, and the selection of the scheme. I think if we are having a patient who have, as I say, different mutations that are STK11, KRAS, and patients that have a history of a lot of symptoms, actually, or a burden that is very high, I will go for maybe a combination, even if the patient have in a very selected patients, obviously, in patients that are very young, the case that you are putting there together. But we need to remember also that in several of the other patients with 50%, not all the patients are able to, if they are elderly, they are not able to tolerate very well the combination in some cases. So we don't have to, in patients that we are not really able to cure completely, we are not able to give them, we don't need to give them more toxicity. So in these cases, need to be very careful, the decision.
And does the baseline burden of disease influence how long you give immunotherapy for? Because most of the time, if you have a sustained response, you probably would stop after 2 years, like you showed, that data. But what if that patient started off with horrible, horrible amounts of disease, like full of liver mets and lung mets and bone, like PET scans, lit up like a Christmas tree, and had brain mets and responded beautifully? Would you stop at 2 years?
That's as I say, it's a difficult discussion because unfortunately we don't have any biomarker or nothing that tell us, and it's our intuition and how the patient is developing. But if a patient is developing a very good response, generally are the patients that are very scared to stop the treatment. So they discuss with us and say, I'm really scared that this is impacting and coming back immediately. So I think in some cases with the excellent response and with a very high risk factors, and if the patient was tolerating well, we can go over the 2 years. But I think we need the studies, obviously, to answer that question because it's a very important part. Also, some of the patients are having experience. So there is a concept. Some doctors are doing also like a vacation period and back or extending the days of the administration. We now have also a subcutaneous administration. So there are also other options that we can make the patient a little bit more comfortable. I don't know if I'm.
No, I understand. I understand because I have a patient right now.
Oh, sorry, I looks like was freezing. Everybody was freezing.
No, no, we're just very still. We're listening to you. So no, because I have a patient right now, 4 years on single agent pembrolizumab, was a heavy smoker, very high PDL1, a lot of disease with brain mets, and he never got radiation therapy for his brain mets, but he went into complete remission. And he is
Oh, wow.
very scared to actually to stop the immunotherapy because he had brain mets to begin with, and that responded to the immunotherapy. And I sort of agree with him because I also don't have the guts to stop it. So,
Yeah, and actually, I think liquid biopsy will be a great opportunity there. We
MRD
have
testing.
different data already that they using the technology to look the kinetics of ctDNA if they are regrowing, but this is still experimental, so we cannot use that as a decision maker.
Absolutely. Dalia, I think you had a question, or Dr. Zamzam, you had a question.
Thank you very much for presenting that interesting case. Maybe as a comment or maybe a question, did you rebiopsy the patient when he progressed, and did you do a molecular before starting immunotherapy again? And would you as well restart the chemotherapy once they progressed after 2 years? Would you add the pemetrexed at least as a maintenance? And in your practice in general, maybe Dr. Shaheen and yourself, if patient tolerating the combination very well with the pemetrexed, would you stop pemetrexed as well at the 2 years of if you have that patient, was he on single or with the chemotherapy? How you go with the chemotherapy if they are tolerating and they completed the 2 year with the immunotherapy and you decided to prolong? Will you give them a holiday from the chemo and continue? Or?
I have an add-on to that question to Dr. Rolfo, and that is in your case, you gave chemo plus immunotherapy, but then you did maintenance pembro on its own for 2 years. Would you have considered, based on, say, the tumor burden PDL1 status, to perhaps maintain on pembro plus immunotherapy? I think that's what you're trying to ask.
Yeah, pemetrexed.
Yes, so would you think about that? We'd obviously drop the carboplatin, but a lot of us sometimes, especially in those PD-L1 negative patients or those patients with high tumor burden where we're just, crap scared of stopping something, would you, maintain with pemetrexate is the question here.
Yeah. So thank you, Dr. Sampson. Several very nice questions. I will try to remember all the questions that you put there. But so the first one is the rebiopsy. So generally, in this case, it's not my case, but I know that the patient was going to pleural effusion, and they analyzed the pleural effusion and was positive, and that was the case. They didn't repeat NGS, but what I do generally in my consultation, because this depends obviously of the access that you have, no? But generally in these patients, what I do in the very beginning in the diagnosis, we are doing liquid biopsy, tissue or liquid biopsy at the same time. And if we have an information coming from the liquid biopsy, I don't re-biopsy, but I do the liquid biopsy again to see if they maintain the same pattern. Obviously, if you have some cases that they are a little bit more difficult and you want to understand if the histology was changing or something, we prefer histology, obviously. The maintenance, and we try to do both. So that's the idea, no? Because the studies show that the data that they show were both. But if you look the studies as well, a big number of proportion of patients were not able to continue pemetrexate all the time until the 2 years. So that is also, it's happening in the reality because some patients are having some issues, especially elderly patients that they are not drinking very well. They can have some issues in the creatinine and starting to have some problems, and also, or they are more tired or they are not tolerating very well. So in some cases, we stop it. In this case, I think was stopped for that reason. And they continue only with pembrolizumab. But the studies originally were planned to go for the combination.
Dalia, what are your thoughts over here?
I think I will not add more. I usually do retest. When I reintroduce the platinum for the question of Dr. Zamzam, yes, we do that. We reintroduce platinum again if a patient recur after long BFS. Yeah, it's a common practice. But honestly, I am not sure about your question and the comment by the Professor Rolfo about the patient with the mixed commutation. Even if the patient has a high PD-L1, like 100, I have a similar patient, 100% PD-L1, low tumor burden, not high tumor burden, but with commutation like that, like this, the SKT11, the KEAP1, honestly speaking, the response is not great. I started the patient on chemoimmuno, but I didn't see a significant response. There is a control of the disease, but it's not that significant. I'm not sure if this commutation considered to be poor prognostic factor in this group of patients with even very high PD-L1.
Yeah, no, I think this
Rolfo?
also you have their data that they say, no, that we started with very retrospective data and now we are accumulating prospective data on that. But I think they are playing an important role in the prognosis of the patient. So, and there are studies designed for this specifically. Some institutions like MD Anderson, Dr. Skoulidis is one of the experts of this, and they are customizing the treatment according to this as well.
So do you, in patients with STK11 and KEAP and other co-mutations like RAS mutation, do you prefer dual immunotherapy rather than single agent immunotherapy, irrespective of the PD-L1?
Just for Dalia, I think. No.
Me? You're asking me?
Yes, I'm asking you, Dalia, and then I'm going to go
No,
back to Dr. Rolfo.
no, I don't think
Otherwise,
so.
all the questions are coming to me.
No, I'm asking Dalia. I'm asking
Okay, no, I
Dalia
think
because she
I
said
don't
her
think.
patient didn't respond, so I want to know what she is going to do in the
Honestly,
future.
I don't think this will be the correct way to target this patient. In the presence of this co-mutation, difficult mutation to treat, I prefer the chemoimmunotherapy, even in presence of high PD-L1, like 100%. I will not go for only immune checkpoint inhibitor in this population, honestly speaking.
I agree.
Okay, Dr. Zamzam, what are your thoughts over here? Are you first of all, are you testing for all these co-mutations? Because not everyone tests for it. And if you're testing, do you act on it?
For sure. So we do have a comprehensive panel. So all patients in my practice get upfront cell-free DNA and comprehensive NGS with more than 500 genes tested. So we do detect all of those mutations. And I think we need to stress that most of the data were retrospective for the STK11 and the KEEP1. So it's all retrospective. It was not really powered to detect, but we that it is prognostic. It might impact our treatment. But I have seen patients with those resistant mutation and they do respond. In fact, I do have a similar case to Dr. Rolfo that has KRAS G12D and with the KEEP1, and he stayed on immunotherapy for 2 years, just progressed after 9 months after stopping the immunotherapy. But at least he stayed for 2 years, which with those prognostic, I would say resistant mutation, you would expect a shorter duration of response. So I think we shouldn't generalize, and I think we should maybe advocate for using combination therapy instead of only monotherapy, immunotherapy, because we know those resistant mutation might act early on in the disease course, and we want to suppress that hopefully as much as we can, and then we gain the benefit of immunotherapy later on. So kind of you make the tumor more hot, and maybe you increase the tumor microenvironment and the neoantigen, and hopefully that will work. Like that is the addition of chemotherapy. That is the kind of really the perspective why we add the chemotherapy, to make the tumor more hot, and hopefully the immunotherapy will work better. And I do have as well patients who are PD-L1 80, but I always personalize. I just always look at the patient profile. If it is a high burden disease, particularly liver metastasis, I would definitely go for the combination. I wouldn't choose single agent immunotherapy. And I barely use the dual inhibition, immune checkpoint inhibition. That is, I use it for the elderly, especially the checkmate 9AL, where 2 cycles of chemotherapy might be really beneficial for those elderly patients. But for my young, fit, who fulfill the profile with high burden disease, I will go for the combination. If there is the commutation, I go for the combination as well. Only those pure patients, very, very few, honestly, whom I start monotherapy, I'm very hesitant. So I always start the combination unless I have very good reason to just choose monotherapy over the...
So let me ask Dr. Rolf the question, and then I'm coming to you, Sonia. I know your hand is up. I haven't forgotten you. So Dr. Rolfo, she brought up a very important point. Dr. Zamzam actually brought up a very important point. In a patient, she has a patient co-mutation, and she gave 2 years of pembrolizumab. Patient did well, and then stopped, and then 9 months later, the patient progressed. Is that what happened, Dr. Zamzam? So should we be thinking about, there's no data, of course, but this is real world that we're talking about here. In patients with co-mutations, where we know their prognosis is worse compared to those who don't have co-mutations, should we think about continued maintenance of pembrolizumab rather than stopping after 2 years? Dr. Rolfo?
I think so. If the patient is having still a benefit, if he's not progressing, I will continue. Maybe in these patients, he's having a benefit. If we discuss with the patient, that will be continued. The other scenario is what we are doing with these patients when they are progressing in very short time, in 9 months. So that's our resistance that are rising. Actually, we have some patients that are refractory, and in these patients, the continuation or the rechallenge, when they are very short time for resistance, the rechallenge is not an option. They are not responding a lot for this patient. And actually, Dr. Dalia was putting a big example there where the patient is having a big progression-free survival. I can rechallenge and actually introduce maybe the reskin with carbo and so on. But in these patients, if we don't have clinical trial, unfortunately, we need to go for the traditional docetaxel that we want to run away, no?
So what is
yeah, go ahead.
Sorry. So what is our definition of re-challenging? After how much? Is it like 1 year? where you consider it is good to re-challenge after like stopping the treatment after 2 years of completion? Is it the 6 month? Are we applying the same like platinum kind of refractory
Yeah.
rule? This is more like, I don't think we have a very clear definition of it.
No, absolutely. We don't have it. Actually, that's a great point because we are extrapolating this 6 months rule that is coming from other tumors that we don't know if we need to apply or not. But we don't have, as I say, here is a big area that we need biomarkers. We don't have nothing. But I think we are basing on the results of the patient had, the longer progression-free survival, and the opportunity to treat. But in cases that you have very short time after you discontinue the treatment, and they having a wave of the disease, and depends also the burden of the disease that they are having, no? Because if we are talking about oligoprogression, that is different.
So
And
Sonia,
I think Sonia have a question for Sonia that we leave it.
yes, Sonia had her hand up and we haven't allowed her to talk because we're talking so much. So Sonia, please ask your question.
I'm very patient, thank you. So, 2 or 3 points, and thank you very much. I mean, the majority of the questions have been said. Now, for the like mutations, dual mutations, and the aggressivity of disease, also, I do prefer to go for combo with the chemotherapy rather than single agent, even if the PD-L1 is very high. Dr. Zamzam said something very well, like if patient conditions or age maybe does not allow to use chemo combo with immunotherapy. I will go also, we know like there is the checkpoint 9LA, but just a small example, I have a patient who is 81 years old, okay, and he has PDL1 of 90%, and he came almost dying on ICU, and he was having massive pleural effusion and so bilateral lung metastasis. And after like 6 cycles of Pembro, it's a miracle. Eventually, his family are thinking like what, like they were thinking not to treat at all because they were thinking to like palliative and they refuse treatment. But this kind of patients might also respond, and he has the SKT mutation to pembrolizumab single agent because he was a heavy smoker also. So this is the conditions that you take. Secondarily, if I have a patient who like is having also mutations and showing the aggressivity of the disease and young, rather than to give like immunotherapy, I will add the chemotherapy because we know like chemotherapy is like not something static, like it will kill the cells, and then I will control with immunotherapy. And same history of yours, Dr. Shaheenah. I have a patient who have been almost 4 years on Pembro maintenance in complete response. He was Jordanian young guy, and this I treated him in another hospital. Then he followed me, and he had a brain mets also, liver rejection, and massive liver metastasis. And he stopped it only because his insurance was finished, and he has to go back to Jordan. So there is like examples like that which will keep us really having the mindset to give the best on the right time. Because if we don't think about it wisely, we will lose our patients, especially those patients with the very aggressive disease.
No, 100%.
This is my perspective of seeing things between the combo and between the checkpoint with the like anti-CTL4. And regarding the rebiopsy, like if I have opportunity to rebiopsy, and if the patient, of course, agree, we know like not all the patients would love to have a biopsy because they will think about more spread of the disease. I will do. Not because I will maybe find other mutations, but to check, as Dr. Rodolfo like says very nicely, maybe we have something different, and maybe there is transformation to small cell in very rare cases. So this is the only reason that might keep me looking for a tissue biopsy. Otherwise, that we have the liquid biopsy also is more than enough for us to be used.
Thank you. So Dr. Rolfo, coming to PD-L1 negative,
Yeah.
or I would not say negative because we seem to be using the cutoff of 50% to whether to use immunotherapy or not.
You mean less than 1%?
Less than 50%.
Or less than 1%?
Less than one. Let's look at both scenarios.
Because the negative is the less than 1%. We
1%.
consider less than 1%.
So let's look at both scenarios. You have a patient, your patient, PD-L1 was 40%. I feel like that's semantics. 40% versus 50%, as a cutoff.
Yeah,
40%. Would you have ever thought about giving single agent immunotherapy?
no, no.
Okay. So
No,
you say
and
that's
actually,
a hard and fast rule,
PD-L1
50%.
is a very imperfect biomarker. So
Yes.
they're talking about a biomarker that have intra-tumor and intra-patient heterogeneity. You have in a same sample, and for sure somebody saw this paper and publication that there are sample, and you have part of the areas that are highly expressing and areas of the same tumor that are negative. So we are just guessing, I will say, with this certification, but that is the only biomarker that we have at the moment. So we need to try to use, and I prefer to go for the combination, obviously. And then in the other scenario is the question when we selected in the less than 1%, which kind of a scheme I need to go. And because some people believe that it's only the negative, we need to go all for the dual immunotherapy combination, but it's not true because we have differences in both. Obviously, if I have a patient that have an PD-L1 negative, but is an squamous with brain metastasis, in that case, the data are in favor for a 9LA, for example, because we know that they have in this specific population, the overall survival in 5 years was higher in this population. But in the same scenario, just changing the histology, the data for PD-L1 negative with non-squamous is a preferred option will be the combination with chemo and pembro because they have there an overall survival that is higher. We were seeing around 29, almost 30%. So that's are the things that we need to always look. No, specifically the histology is a very important component, and the brain metastasis. Both drugs and you put there very nicely a case that is years with pembrolizumab in response. So the data, we don't need to forget that are data of sub-analysis. So generally we are taking, but the data in this case for the brain metastasis and the sub-analysis, that was happening also with other drugs, no, that they did the similar. Cemiplimab was doing with liver metastasis, and but the thing is that we don't have a clear prospective trials specifically in that sector.
So, Dr. Zamzam, these patients that are PD-L1 negative, defined as less than 1%, do you treat them any differently compared to patients who have more than 1% or who are PD-L1 positive?
Not at all. I really treat everybody the same. I think my first or the drug of choice is pembro with the platinum based, whether it is squam or non-squam. The only thing that I will reconsider if it is like really negative and they are elderly and less likely to tolerate the 4th cycle, I will go for checkmate 9LA. And the other consideration as well, if they are, I don't know, never smoker with this kind of really never smoker, no driver mutation, they as well tend to do not well. So maybe those two groups that I would maybe think to use the combination. But my majority of my practice is pembro and with the platinum based. I really don't treat the more than one differently than less than one. Now
So why
here
do you test for PD-L1 then? Everyone gets the same. So why do you test for PD-L1?
I don't believe that much.
I'm just playing devil's advocate here. So why do you test for PD-L1?
It is a guideline, but I'm not a big believer at all on PD. I feel that there is a better biomarker that is yet not discovered for the immunotherapy. I think we are way behind in defining what is a good biomarker in this group. Lots of work has been done. I don't know, there is not lots of there is now lots of talk about the microRNA signature. We haven't seen those studies a lot in lung cancer, to be honest. And it would be really good to see if there is any specific signature that might predict response to immunotherapy. That is one of the things that was really thinking and trying to address trying as well to see if I'm going to get a grant to address that thing. Already started to think of having that, but I really don't have a good number of patients to test. Like our almost driver negative, I would get maybe 20 to 30 cases per year, which is not an enough number maybe. But yeah, that is something to explore. I think this area is very rich. BDL1, I'm not a big believer on BDL1. I do test just to see. It will predict some maybe response. It will give me some, maybe satisfaction that I did and it is there. But I believe there's a better biomarkers other than the BDL1. It is still not, we don't know it. But that is the best that right now. So I know you would say, I've never.
So let me ask the question. Let me ask Dr. Rolfo the question. Is TMB a better biomarker than PDL1, and does it drive your decision-making process?
No, unfortunately not. And I think we lose, personally, I think we lose an opportunity with TMB because we was very in hurry to get any other biomarkers, and we was trying to get TMB. But we applied that in a very incorrect way. So we was, first of all, applying to all the tumors, regardless of the histology, regardless of the expression of PD-L1. We was using different technologies, different thresholds to define, so it was not really applicable. There are some studies that were staying there in the time when we started all the history of TMB, but were more dedicated to histology type, one tumor type, specifically also in correlations with some, not only the histology, but also the stratification of PD-L1. And that study is looking for some specific mutation were pilot study were showing a better correlation. So we have, I think we lose the opportunity with TMB in lung cancer. I'm not talking about others, but in lung cancer, it was a bad opportunity that we didn't take it properly.
Dalia, what are your thoughts on PDL1 negative patients? One, how comfortable are you giving immunotherapy to these patients? I think pretty much everyone is, but whether to give it with chemo or not. And do you consider dual immunotherapy in these patients?
I think I cannot agree more, as Dr. Rolfo and Dr. Zamzam said. For BDL1 negative, yes, I do the combination. I may consider the dual IO plus chemo, the 9LA in, for example, for this specifically the squamous subtype. Only immunotherapy, I consider it as a monotherapy only in patient, very frail patient, very old patient with a strong BDL1 positivity, like more than 70, 80%. I may consider it in this only group of patients, but otherwise, I use the combination strategy overall.
So, Dr. Rolfo, if I may ask now, all our patients in the early stage setting are getting immunotherapy with chemotherapy. When they relapse, what should we do with them, especially if their PDL1 score is still very high?
Depends also of the type of relapse. If they are relapsing very shortly, it depends on the trial that you was, or the kind of drug that you was using in the beginning. If you're using, for example, Checkmate 816, is different that you are using the IgM, for example. So, but will depends a lot on the progression-free survival time, how you are treating. Obviously, if they have a still PD-L1 high and you was using the opportunity, for example, Checkmate 816, and the time is time to relapse is not in just after the surgery, we have the opportunity also to treat them with chemoimmunotherapy. And I think it's a great opportunity for them because you are using in a different way. So actually, my concern for the early stages are what happened in patients that we have, like in the Aegean trial, that you have perioperatory and you have a patient that is not responding properly in a major pathological response. I'm not talking about pathological complete response, but you are continue to treat a patient. So we don't have also data what happened there.
Interesting. So, Dr. Zamzam, what are your thoughts? What are you doing for patients who are relapsing after perioperative immunotherapy? Dr.
Are we
Zamzam?
talking? Yeah, sorry. Are we talking now in the perioperative setting?
No, I'm saying, what if they relapse post perioperative immunotherapy?
Relapse after how long?
So,
That's
yeah. Very good question, Dr. Zamzam. You tell
Yeah.
me what you do at various time point cutoffs.
Okay, sure. So, so to start with, I think I have in my practice now, because we see, unfortunately, most of our patient is really advanced. So with those whom I treated with perioperative, we had maybe 6 cases since last year where they were treated with the perioperative. I think majority of them did very well with the immunotherapy, and at least 3 or 4 of them completed. 2 of them completed the 1 year, and then 2 ongoing. So I haven't really had a relapse immediately post the immunotherapy. But I think it is a very important question to ask: when is the relapse? I think if it is less than 3 months, we don't have definition, to be honest. Less than 3 months, I will feel it will be very hard to kind of really re-challenge after that brief period. So they are, by definition, I think, resistant. And I will go maybe for testing again, and it depends on the relapse, oligo metastatic or local versus systemic and widespread metastatic. So if it is oligo, we might address that with the stereotactic radiation and so on. But if it is widespread metastatic, I would definitely rebiopsy. I usually rebiopsy or send cell-free DNA. If cell-free DNA is negative, I do tend to rebiopsy all patients to have more understanding of why they drove this resistance so early. Is there anything evolving in their histologies? And if there is no answer from the NGS, it will be a chemotherapy if it is less than 3 months. If it is more than, if it is within the 6 month or at the 6 month and beyond, I would definitely feel more comfortable re-challenging with the immunotherapy, starting again immunotherapy. There is really no evidence behind it. But I don't know, I'm with the platinum. I think that definition fit it all, the 6 month kind of thing. It
I love
seems,
it.
just tell me what do you think? But that is what I
No,
usually,
I agree with you. I agree with you. I'm actually curious to know what Dalia thinks because she's contemplating what you're saying. So
No, no, no,
I want to know what she's
100%. I
thinking.
totally agree. I think this is our practice. I don't have a lot of patient failed on perioperative approach. Yes, it's a very new concept in our area. The perioperative approach, we don't have a lot of cases. Most of our patients present with advanced stages. So if it happened with me, any of my patients, I would consider the time from since I finished the treatments. As mentioned, we don't have a definite period to decide whether the patient is platinum refractory as the ovarian cancer setting or the platinum sensitive. But overall, we agreed in the community to consider the 6 month as a period to consider re-challenging with platinum overall. Even the compelled trial, not the compelled trial, when we you need for the other even the EGFR mutated patients, when we introduce the platinum again, we consider this time as well, the 6 month. But 3 or less months, I don't consider it challenge, at least with the immunotherapy.
All right, Dr. Rolfo, let's just go a little bit futuristic here. I know there's a lot of data now looking at antibody drug conjugates in the first line setting in combination with immunotherapy. What are your thoughts there on this particular aspect? And then we have also the fact that bispecifics are coming into play in that first line setting. So can you give me your thoughts?
Yeah, so seems that the moment now the bispecific was a couple of years, and now we are more in ADCs. And so still there are some bispecific. There is still some trials that are going back to some all-known friends like TGIT and others. But for ADC, I think it's a great opportunity. The only concern, or one of the concerns that I have with ADCs in lung cancer is the use in without biomarkers. So we need to be very careful what we are doing with them, and also obviously toxicity is an important part. And then what happened in some scenarios where you have similar ADCs have the same payload. So what happened when you have resistance with them? What will be the sequence of treatment with these ADCs? But I think it's a great opportunity. Having the combination with immunotherapy will be a next step, and toxicities. I want to make sure, specifically for ILD, what will be the future, because it seems that the pneumonitis from immunotherapy is completely different than the pneumonitis that we are getting for ADC in terms of settling and also the management.
So, Sonia, what are your thoughts here? How do you think the future is going to be in that first line setting?
I mean, definitely, I don't think that we will go far from the combination, except for the PD-L1 negative. I think we might have more thoughts about the presentation of the patients, and still I will go for combo. And yes, you're right. So why we are testing the PD-L1? Because for me, it's also prognostic, and it will make me more courageous to continue with the immunotherapy. Now, there is de novo treatments and a lot of research in the genomics. I think that this is what we need to look for in the future. And I think not all the patients are the same. And we might have sometimes heterogeneous disease. So that's why for me, the biopsies are very important to check and to chase. And still the future will be for me for such patients with pembro and chemo, because I have been seen a lot, and really my experience was amazing. Of course, we have some bad patients that progress and they did not do well, but my experience for such patients with pembro and the combination did very well. So this is my input.
So I'm going to ask a last question because we just have a few minutes, and I'm going to be a little off topic because we're supposed to only be talking about metastatic, but we have Rolfo here and all of you guys are here. So I'm going to ask the question, Dr. Rolfo.
Christian, go for Christian. That's my name. Because I was naming everyone with their name. I'm sorry about that. But please, Christian.
Is it for you in the early stage setting? Is perioperative immunotherapy strategy the same as neoadjuvant? Really asking the question, do we need maintenance immunotherapy in that? Do we need adjuvant immunotherapy in that early stage setting? I really wanted to ask that question. I'm going to ask everyone that question afterwards, and then we're going to close up.
Yeah, no, I think we cannot compare pears and bananas. Are different different trials, different approach. I think both are valid. My only point would be that, as I said before, I'm concerned to maintain a treatment or do a treatment in a patient as adjuvant when we don't have a good response, and that will be one of the things that I would like to have a better understanding. And the other part is that logistically, in some places, it's not possible to do all the same. So doing in some places, starting the neoadjuvant could be a problem because we don't have the surgeon in place, and the time for the surgeons can be delayed, and so it's difficult. And other places doing the adjuvant is difficult as well because some patients have complications. So the delaying until you start after the complication and recovery of the surgery could be also a logistic point that we need to consider in the effectiveness of the therapy. But we have here a lot of patients in early stage, and we used to do more neoadjuvant in that patients because we have a good environment with the surgeons, and they are habituated to this kind of approach. And actually, we are receiving patients that are referred by the surgeons to do neoadjuvant, and that is a good thing actually for our patients. Obviously, the patients want to be operated and want to have this out immediately, but you need to explain also the curves of survivors and other things in the discussions.
So I just want a yes, or I want just one word answer. Dalia, what do you use in your clinical setting? Perioperative approach or neoadjuvant approach in the early stage setting? Perioperative. Dr. Zamzam. Just one word answer because we need to log off.
Hybrid.
Dr. Zamzam is.
Some patients are the
Please go ahead.
only the adjuvant, and then there is patient whom I will go with the perioperative.
Okay, so
there is
not
lots of talk on this one. That's why I wouldn't. Yeah, I will be diplomatic. I will say perioperative for now, but I have used it as well in
Okay.
the.
Okay, Sonia, just one word answer. Perioperative or neoadjuvant? Because I have to sign off.
Okay, perioperative, but if I have a patient who is very early stage, I will go for surgery, definitely before.
No, I'm just talking about the patients that fit the criteria. Is it perioperative or neoadjuvant?
Peri.
All right. I need to have a separate conversation with Zamzam at some point and ask her thoughts. But she's right as well. There are some patients that you probably would only consider neoadjuvant, especially, I think, in my opinion, if finances is an issue. So thank you all. I think this has been a fantastic EIOC Journal Club. I got to ask all my questions, so I'm very, very happy. Thank you. Professor Rolfo, thank you, Dalia, thank you, Zamzam, and thank you, Sonia, for all being so amazing. And I hope to see you all at the next edition of the EIOC Journal Club. Thank you.
I
Thank you
hope
all.
that
Have
we
a good
can
night.
do in place there.
Yes, in
Hopefully.
person. We
Yeah.
need to get you over
See
to
you,
Dubai.
inshallah.
It's so hot and nice right now.
It's
Yes.
also
All
Have a
right.
lovely
Thank
evening,
you,
all.
everybody.
Thank you.
Thank you. Take
Bye-bye.
care.
Thank
Take
you.
care.
Bye.
Bye-bye.
Bye.